an ABT with one or several antibiotics. Thank you so much, Fabrice. Welcome. Thanks for still being here to listen to me. I'll try to talk a bit about antibiotics. So I need to talk about the first day of antibiotics, what you need to do at the beginning, and then I'll hand over to my colleagues to know how to manage antibiotics at the end of a treatment. The basic situation, that's one possible situation that's increasingly frequent now. A man with a history, here ENT, recently diagnosed ENT cancer with a neoadjuvant chemotherapy, but without neoplastic syndrome, respiratory distress, shock, MODS, purulent aspect in the tracheal suction, high number of PNNs, a few positive cocci. So what antibiotics, what spectrum, mono versus combo? What antibiotics am I going to give these patients to be sure that I can treat a pneumococcus pneumonia, which it looks like, but also care-associated pathology. So I need to choose my antibiotics. What spectrum? I need to think about that. If I use a mono or bitherapy, I would like to have fast activity, or at least to kill off the germs in charge of the symptoms quickly. Diffuse in the infected tissue, have high enough concentrations to reach the infected site and cure it effectively, and avoid toxicity with the drugs that I use. Those are the key words of antimicrobial treatment. Optimizing treatment, you need to be efficacious, safe, and cost effective, rather. I'm not going to talk about cost of treatment, but an acceptable cost by protecting other patients. What does the Surviving Sepsis campaign say? In severe patients, you need to treat very early, within the first hour. So, literally the first hour after septic shock. The more severe the patient, the earlier you want to treat. Of course, it's hard to grade because there aren't really any randomized trials about that, but there are a number of data. You need to reach the pathogens that are responsible for the infection, so you need to be active against the pathogens, penetrate tissues in high enough concentrations in the tissues that are presumed to be the source. So if the patient is more in severe sepsis than septic shock, maybe you have a little more time, but the data aren't great. And so there's a graduation between dramatic treatment, which is inadequate, not active on the germs, but not active in terms of pharmacodynamics of the antibiotics. You're not in the right place with the right dose. Very often you have adequate treatment. Okay, the antibiogram is okay, but it's not great in terms of PK, in terms of pharmacodynamics of antibiotics, especially in the first day. There are big problems. And what you need to shoot for is the green box, rightly delivered antibiotics at the right dose, active against the responsible bacteria, and you're happy. There's probably a direct relation between the mortality rate and the way you do all that. The problem for us is the therapeutic index, the way we can reach a final diagnosis. And quite clearly, there are two problems. There's the adequacy of the antimicrobial therapy and multi-resistant bacteria. Whatever the methodology with a multivariate, multi-center study, it's not resistance that kills patients, because resistant germs are not more virulent than others, but it's in the appropriateness of the therapy. So in severe sepsis, there's a negative impact of resistance and inappropriateness, but if you have a regression, multivariate regression, it's only the inadequacy that kills patients, but the multi-resistance is more associated with inadequate antibiotic therapy. So the patient had pneumococcus, and so requiring only the right dose of amoxicillin or other drugs if there's another germ with a lot of selection pressure. In Eurobact, hospital-acquired and ICU-acquired bacteremia, the more resistant the bacteria are for the bacteremia, the more the time between the blood culture and ABT is long. you can see the number of patients receiving the appropriate ABT, and the times increase very fast. Less than 3 hours for adequate treatment when you have an extensively drug-resistant or pan-drug-resistant bacterium. It's less than 30% of efficacious treatment, and use only 40% in the susceptible drugs, susceptible germs. And well, when we discuss things between us, things go great, but in fact it's not so simple. There are a few keywords beyond shock. You need to strike fast. But there are a couple of interesting studies that say that, okay, you need to be aggressive in treatment, but you need to know what you're doing and not just do each and everything. If you do each and everything very fast, it's probably less good than taking a bit of time to think and do things right. This is a pre-post study with a number of biases. In the first period, they had super aggressive protocols treating all patients with ICU-acquired sepsis, which changes things a bit. They were all treated aggressively with a very broad empirical treatment very quickly. In the second period, they were a bit more conservative, waiting for blood work results. If the patients were too sick, they gave them antibiotics, taking time to think about their knowledge of the antibiotics received before inducing treatment and comparing the two periods, what it meant in terms of efficacy. This is a population of surgical ICU with 50% of trauma. Overall mortality is not very high, 5%, so they don't have a lot of problems with infectious diseases. Maybe they handle fewer antibiotics than others. 247 in each arm, having an acquired infection, a few imbalances regarding pneumonia, gram-negative resistance drugs, Staph aureus, methyl R, but nothing too bad. And what the study shows that it's very effective in terms of time in the aggressive arm, maybe not 1 hour, but 6 hours. For the other one, 24 hours, people took time to think. And what's interesting, what's surprising, it's a very provocative study showing that aggressive treatment increases the risk of death with an odds ratio of 2.5, which is fairly high. And even in shock patients, the same outcome for shock patients, which is surprising because the mean arterial pressure is even lower in the conservative arm than in the aggressive arm in this study. What can you say? Of course, there are a lot of biases in this problem. It's probably that if you strike very strong, but if you do anything, it's probably less good than if you do things cleanly after taking some time to think. It's the conclusion that you can draw. Of course, it's a before-after study. Probably the aggressive treatment, if you don't know what you're doing, is not enough. You need to to think out things. There's a learning curve during the aggressive period. People gradually learn what to do, and they do less and less bad over time. So too early, too aggressive is not necessarily associated with improved survival. Second message, forewarned is forearmed. It's good to know guidelines, but you need to know how to apply them, and that's very important. This is a very provocative study as well about the HAB-VAP, hospital-acquired or ventilator-acquired pneumonias. And they compared patients for whom they strictly followed the guidelines of the American Thoracic Society versus patients for whom they infringed the guidelines. They reduced the coverage of MRSA, or they didn't use dual treatment in some cases. And they realized that treatment was active in the two groups, 81 versus 85%. And in fact, what's a bit provocative, but nonetheless important, you improve the outcome, less exposure to antibiotics as well, fewer adverse effects if you infringe the guidelines, provided that you know them and you know why you don't follow them. This is a major message, and that's also the message of this study. They have a propensity score, it's adjusted and so on. I'll skip that. And whatever the group, the subgroup of patients that you take, there's this slightly surprising, highly provocative result, but nonetheless interesting to bear in mind. So, of course, consensus conferences are good, but if you haven't digested them, you can't do things right. So what do you need once you've said all that? You need to act very fast and do things well. You need to know the epidemiology, the global epidemiology based on the foci that you know. Be aware of care-associated infections that are increasingly common. It's a mixed bag of infections. That's very complex. People have lumped everything, chronic dialysis patients with antibiotic treatment patients, those that receive previous care without ABT, those who have home chemotherapy with bed sores, and people say that it's care-associated infections. Chronic dialysis patients will have an Staph aureus infection, whereas a patient in a long-term critical care, an elderly person with difficulty swallowing, will have Enterobacteriaceae, whereas another patient will have a Pseudomonas infection. You need to know what to do before you decide on an ABT, but there are warning signs about that. And of course, there are hospital or ICU acquired pathologies where you'll consider the flora of your hospital or the flora of your ICU to decide on an ABT or based on the samples that you took. Of course, you need to know the guidelines to be able to apply them most of the time and to know also when and why not to follow them. I think that additional tests to try and document the infection are absolutely fundamental, especially in ICU or hospital-acquired infections, and in case you suspect multi-resistant bacteria. If you haven't taken samples after treating, and if you take samples after treatment and results come back negative, you don't know whether it's effective and when to stop. And you need to have basic knowledge on the spectrum, diffusion in tissues, and adverse effects associated to the antibiotics that you use. And you also need to know what is the patient, that's the flora in the ICU, and your patient flora. You need to decide on the right dose, right route of administration, and decide on mono or combo therapy in what cases. I won't go through everything, that's too much, but whatever the severe sepsis, pneumonia is the number one cause by far, then rather intra-abdominal for hospital-acquired, and rather urinary. But for severe sepsis and urinary infections, usually we have complicated urinary infections with obstacles, and that's the third cause. And then catheter-related infections, patients who are already treated for something else. And so you have these causes, which are the main ones that you'll work on a daily basis to know what antibiotics to use. You need to take a sample regarding the cause that you suspect, and I like a direct examination. The problem now is that it's increasingly, bacteriology is increasingly automated with less staff, and at night you don't always deal with true microbiologists, people who are trained for 2 months and who can no longer read a direct examination, and here this really loses its relevance. So discussion with microbiologists to see whether the guy has seen the exam and he stands by his decision, by his interpretation. Of course, we'd like to see a great thing. You send the sample to the lab, they say that it's that germ, that resistant profile. You can use the antibiotic that you want, and it's all happens within an hour. We're not that far yet, but we could hope that in a little while they could do that a lot more, a lot better and faster than they do now. There are avenues regarding the detection of resistant germs. Pangenomics is difficult. People are starting to work on that. It takes 3 hours. You can have a large panel of bacteria and a large panel of antibiotic sensitiveness. There's a paper that's just been accepted in the Blue Journal about it, and there are a number of patients coming out papers coming out, and it's great. It costs a lot of money, but it would be possible to get something. And when your culture is growing, you can de-escalate faster if you've got molecular biology. Be wary of gram stains. A gram stain of a positive coccigram takes less and less, because gram stain because the bacterium is dead, and it looks like a bacillus. And the germ transforms very quickly after amoxicillin, so you could be mistaken. You need to discuss it with the micro guy, and also based on the antibiotics that were received before. If it's a coccobacillus gram variable, but it's already received two doses of amoxicillin, well, it may have changed in appearance. In the emergency room, you need to be aware of a number of things. And what you're interested in, you need basic cocktails about basic ABT, covering a lot of community-acquired germs that are antibiotic sensitive. So you need to think about Pseudomonas aeruginosa, especially for pneumonia. When are you going to think about community-acquired MRSA? What about Enterobacteriaceae that are multi-resistant to third-generation cephalosporins, especially ESBLs? We don't really have a problem with the rest in France. And what about resistance in general with care-associated infections? We've discussed it a little while ago. I think that the first factor in the choice of ABT in care-associated infections is previous ABT. If they haven't received any antibiotics, there's a lesser risk. And the second thing is the history of resistant germ colonization, whether they have bed sores, whether they receive antibiotics, or they've had an ESBL germ in the year. Rather a number of other ESBLs and not an unknown one, well, at least you can see a median time of colonization that's around 6 months. They stay colonized for a long time after they are discharged. If you've got this information, that can be very helpful. And what I said about hemodialysis is important. It's not really the same multi-resistant germs in hemodialysis patients than in others. Another thing that's important, travel. In the community right now, there's a share of ESBL carriers that's very high. In Europe, it depends on the European countries. In Europe, it remained fairly reasonable, but in the US, it was already high. And big warning signs on the Middle East, and very big warning signs on the whole Southeast Asian territories, where ESBL carriage rates are very high, and they're still rising in excess of 70 to 80%. So patients coming back from an endemic country, so to speak, with very resistant germs, then you need to ask a number of questions very quickly, especially if the person's been in a hospital. But we know that tourists going to Thailand, when they come back, they carry more than 25% of them carry ESBLs, although they're perfectly healthy. For community problems, well, you need to know when to use antibiotics others than those in the guidelines, third-generation cephalosporins and macrolides. And that's a big problem, a clear problem. You need to follow a number of basic rules. E. coli, ESBL, or others are very rare. The big problem for us is Pseudomonas aeruginosa. Not anyone gets that. A patient with several courses, previous courses of ABT or a severe COPD. These are the patients that you need to think about anti-Pseudomonas beta-lactamine. For the other ones, you are not losing too much. If you compare community pneumonia with care-associated pneumonia, there are fewer pneumococci, a lot more MRSA, methicillin-resistant Staph aureus for care-associated pathogens, but Enterobacteriaceae are not a lot. But care-associated pneumonia, there's a lot more inappropriate antibiotic therapy. This is the database with 956 patients. We've excluded COPD and immunodepressed patients. Out of 956, you can see the number of resistant or potentially resistant germs. 16 out of 956 and 28 out of 956 that have a PIO but that are still sensitive. See what ICU doctors did? 100 times they used a broad-spectrum antibiotic. This is where we can make gains on the initial ABT, where you can also reduce the misuse and consumption of antibiotics. And here we could probably restrict very broad antibiotics if we know better those care-associated pathologies. You need to know the ecosystem of the hospital and what you receive in the hospital. These are Laurent Sarment-Lefebvre's figures. Thank you so much for our efforts. Here, these are the E. coli, hospital-acquired or community-acquired, that we received in Bichat. You can see an increase in the resistance to cefotaxime. If you avoid the duplicates, you can see that it's not 30%, it's 12% for hospital-acquired. Offlow, well, there's a problem. There are increasing resistances. And for amoxicillin, well, colibacillus raises a lot of problems. That was the same in 2003 and still the case. You see an increase in resistant germs, what we can see in France. This is Bichat Hospital, but it's a fair reflection of what you've got in France right now. It's a big drop in MRSA, a fairly stable populations of A. Beaumanii and Enterobacteria CI, but EBLSC increases, and this year we had 22% of people admitted with an ESBL, which is now extremely worrying. That's one. You need to know all that because otherwise you wouldn't be able to find your way out. And it's not because you've got an active antibiotic that you're active in the patient that you're using it in. You need to know a number of basics in terms of pharmacokinetics and pharmacodynamics. There's a problem with susceptibility. Well, sensitivity. There are strains that are sensitive with 0.1 milligrams and others that are sensitive with 2 milligrams. Well, not that many, but still, if you have 2 milligrams per liter in terms of MIC, well, that means 50 in one case, or 2.5. So the problem is those that you need to ask for tests for the moderately sensitive strains, and there's a problem with concentration very broadly. For some antibiotics, there are problems with low concentration, with high glomerular hyperfiltration for patients who had no previous organ failure, who arrive with severe sepsis, with creatinine clearance in excess of 100 and 150. The rates are not high enough when they're in deep shock. They have a problem with distribution volume, circulating rates that are not good, and with less diffusion in the tissues, difficult access to affected sites. You need to remove the source of the infection and maybe increase the doses, and low therapeutic index for multi-resistance bacteria and Pseudomonas aeruginosa. Very quickly, some antibiotics are dependent. That's the case of beta-lactamines. And here, this is a time above MIC of 100%, or 4 times the MIC at 100%, and concentration-dependent ABX, aminoglycoside Cmax over MIC is over 10, and it's important to recall this message. What you can see in real life in the ICU, it's very rare that these rates are achieved. 100% above the break point of germs isolated in the ICUs of an international studies. That's 10 or 20% of cases for some molecules, and so there's a real problem reaching these levels. And so for that, you need to have strong initial doses, a strong loading dose, even if the patients have acute kidney failure. That's not the problem. Acute kidney failure will be a problem later on for de-escalation. And for time-dependent ones, you need to use continuous infusion or sustained infusion antibiotics over 4 hours. If you infuse over 4 hours, if you have 4 grams of piperacillin over 4 hours, the initial concentrations won't be very high. You need a loading dose, 4 grams over 4 minutes, then 4 grams over 4 hours, and then you can do something decent. Of course, the antibiotic needs to be stable, and you need a loading dose. That's fundamental. You need to measure concentrations. That's important for toxicity. Peak concentration is important for aminocytes, concentration-dependent ABX. And if you need to have a dialysis on a patient who's received concentration-dependent ABs, you don't give the aminocytes after dialysis, but before, and you remove it for 1 or 2 hours. Whilst you're setting up the pipes, you'll get antibiotics. Now, about combo, the relevance is that it broadens the spectrum. I'll skip the rest. It improves bactericidal activity, in particular for the most resistant strains, but otherwise it's not relevant. And regarding the potential relevance for resistance, combo does not have any relevance. It may reduce resistance on the focus of infection, but it may increase resistance in the gut flora. So I'll skip all that because I don't have time to talk about it, but that's anyway tough. So my conclusion, of course, what's important once you've given treatment, you need to calm things down very quickly. Slam the brakes on everything that you've done on day 2. You need to strike very hard, and you need to discuss it with the resident who's writing down the